let's begin. Thank you everyone for joining us today for this wonderful webinar on leveraging EMRs to transform quality of patient care. Please keep any questions or comments towards the end for the Q&A session, but we really welcome as much discussion and dialogue, and we're really excited to get started on that. I will just start by briefly introducing our speakers, and then we will continue on. So next slide, please. Our wonderful moderator today is Pascal Moelle, who is the Palladium Director of Innovation and the Technical Director for the Data.FI project. He will be joined by Christopher Githu, our Senior Solutions Architect with Data.FI based in Nairobi, Simbarashe Chiripashi, otherwise known as Simba, who is the Technical Systems Architect for Data.FI Eswatini, Patrick Ichuki, the Informatics Technical Advisor for Palladium, also based out of Nairobi, and last but certainly not least, Evans Mwenye, the Kenya HMIS 3 Project Process Excellence and Delivery Lead, also based in Kenya. So without further ado, I will continue to invite people into the lobby. And over to you, Pascal.
Great. Thank you very much. Lawrence, please confirm that you can hear me. Lawrence?
Yes, can hear you fine. Perfect.
Okay, great, great. So thank you all for making time. Good morning, good evening, whatever time you are. Thank you that you could find time to join us for this exciting discussion around leveraging EMRs to transform the quality of patient care. So today we have just an hour to discuss this very interesting topic. We'll start with looking at EMRs. We'll first start by a definition of what EMRs are. We will look at the evolution of EMRs, past, present, and future. And then after that, we'll look at 3 case studies that we've chosen to share with you today. And as we go through these case studies, we'll be talking about, our view of the progress made in these different countries, but also the challenges that have been there and what we're doing to address those challenges. As this is Data.FI's webinar on EMR evolution and how we are applying it in different countries, we will also be discussing our guiding principles and then wrap up with our key takeaways. For the purposes of our discussion today, I request that we post our questions, reflections into chat. We will get to them after we go through the couple of slides that we've set up today to guide our discussions. So as we get started, we'll start with the definition of an EMR. So without really going to the specifics of what an EMR and what an EHR is, broadly speaking, we look at EMRs as being very disease area specific or a program area specific. So here you have health information, but it's with a limited scope of a specific disease area or a program area or a specific department. And EHR to be a lot more all-encompassing, to have a patient-centered record that has all the information on diagnosis, cutting across the different areas. But for the purposes of our discussion today, we merge those 2 definitions into EMR. So we'll be talking, as we talk about EMR, we'll be referring to both of these definitions. And in our discussion around the evolution, you'll get to see at one point we do evolve from being an EMR system to being more of an EHR system. Again, as I said, for the purposes of our discussions today, we will use the term EMR. So I'll hand over to Chris to take us through the evolution of EMR systems, both as we've experienced it and also as we adopt a certain framework, and just to give a brief history of where we've seen the EMRs come from and what we see as the future of EMR. So over to you, Chris.
Thank you, Pascal. And please just confirm you can hear me okay?
Loud and clear, and your video is good too.
Thank you. Good morning, good afternoon, everyone. Really happy to be here. I see like 80 people on the webinar, so really happy to be here. EMRs have come a long way. I think over the last 2 decades, we have all in different corners of the world done our best to adapt to changing policy, changing requirements, changing technology. It hasn't been easy. If we look at if we go back in time, we can see that initially EMRs were optimized for data capture. And this was primarily to support HIV program reporting. We then saw EMRs growing to point-of-care systems with some focus on, improving quality of care, targeting real-time data entry. And as we, started to integrate HIV clinics into OPD, the need to go beyond HIV grew. And in some cases, as far as into inpatient departments. Managing commodities, mostly ARV drugs, some billing functionality, are all features that are in high demand. We also need to adapt the EMR for the patient. In this world where that is increasingly connected through mobile technology, we need to start to ask ourselves, how do we use EMRs to power mobility of the patient record, to address privacy concerns and issues of consent, as well as self-care and having a better way to directly engage with the client. I'm sure you'll all agree that the second 90 and attrition and retention in treatment is one of the areas that we're struggling with. So, coming up with new ideas about how we can engage the patient more and understand their experience to, keep them in treatment longer is something that we all would benefit from. So EMRs cannot do this in isolation. And we, over the years, have seen an ecosystem of applications and shared services emerge to support the EMR. Next slide, Pascal. Thank you. So as the ecosystem grows, as the EMR grows, it has become increasingly necessary to assess our current state, assess our future plans against a well-defined framework. Now, at Palladium, we have adopted and slightly adapted the continuity of care maturity model. This allows us to develop systems that not only address short to medium-term requirements, but also to align to a common vision and a longer-term roadmap. So in this slide, we are going to quickly talk about these 7 stages of maturity. And ideally, we at Palladium use this to assess our EMRs, and we feel that this would be a good place to start. And for the audience, at the end of this slide, please feel free to pop into the chat box which country you're working in, which EMR you're supporting, and at which stage you think it is based on this maturity model. So I'm going to quickly jump into it. I think stage 0 is pretty self-explanatory, is manual records. So at stage 1, the emphasis here is digitization of manual records. We expect to see some basic peer-to-peer data exchange between systems, some basic alerts. And here, mostly these alerts address issues of data quality during data entry and some level of data completeness. At stage 2, the focus shifts to patient-centric care within a program area, and in our case here, mostly within the HIV program. At this level, we expect to see improved clinical data presentation. Because we are developing systems to improve quality of care, real-time data entry, we have to be able to design those systems to address the healthcare provider. And to that effect, the way we present our data needs to improve. We do expect to see some limited EMR data exchange at this level. And often we see this happening at the facility level between the EMR and systems in either pharmacy or lab. At stage 3, at this level, we should have a normalized patient record. We should be able to refer patients electronically, either between services or between facilities as a transfer in and out. Now, the only way we can do this is if we have structural interoperability. And at this level now, shared services like facility registries, client registries, start to play an active role at this level. And we expect to see this being actively integrated into the ecosystem at stage 3. At this stage, we also expect to see mobile technologies start to play a role in supporting point of care. And obviously, your EMR at this point hopefully is already aggregating clinical data up the data value chain into systems such as DHIS2. Hopefully, the audience now, we can all start to get a sense of where we are in terms of maturity. But quickly moving on, stage 4. So stage 4 is all about care plan coordination. We need to be able to coordinate our care plans across providers, across facilities, healthcare facilities as well. Again, the only way we can do this effectively is if we have a semantically interoperable record. Interoperability standards like HL7, FHIR become increasingly crucial at this stage, and a well-designed shared health record with policies for collaboration, data consent, data security, mobile device use should all be in place at this stage and should be actively adhered to. At stage 5, we expand to the community. So at this level, we are looking at a community-wide patient record. The emphasis here is on patient engagement. It's on patient experience, improving the patient experience. It's being able to engage with the patient a bit more and understand what's happening once they leave the facility between appointments. We also need to be better at integrating clinical best practices across the community at stage 5. Stage 6, here, we are closing the loop. As we mentioned earlier, we want to make sure that we know we have a big problem with attrition and retention in treatment. So we need to be able to close that loop. We need to understand what's happening with interruption in treatment. We need to be able to understand what's happening with non-compliance. A patient's treatment journey can take multiple pathways, so your EMR needs to be able to dynamically adapt to this. And this is definitely something we're looking into. Stage 7 is the pinnacle of interconnected healthcare delivery. I'm sure we all cannot wait for the day that we have a knowledge-driven solution to comprehensive population health, understanding what's happening in the entire population, on top of what's happening at the patient level. And, with full alignment with global and national policies. So I'm going to pause here, hand it back to Pascal to take us through the next slide.
Thank you very much, Chris. And as you'd requested, I think it would be good as we listened to you to think about where we lie on this continuum. As I said, as Chris mentioned, this is an adoption of the continuity of care maturity model. And through that, you can see a system evolving from being a data collection tool that just primarily serves program management needs to one that is centered towards patient care for clinical care enhancement, to one that supports care coordination across different facilities, to one that is also enabling patient self-care, in that the patients can be able to access their data, interact with their data, manage consent, and the like. So this is a very interesting maturity model that we found. But as we developed and customized and adopted this maturity model, it always comes back to how do we ensure that we can apply this sustainably and at scale in different contexts. And to talk to us about how we can achieve that, Patrick is going to take us through the next slide, which is basically going to give us just a brief on the WHO SMART guidelines. This is not a deep dive, just a brief on what the SMART guidelines are, what they're meant to achieve, and what problems they're solving. So over to you, Patrick.
Thank you, Pascal. Good morning, good afternoon. In this section, I want to just add on what Chris talked about, HIS ecosystem. EMRs don't exist in isolation, and therefore there have been efforts globally to develop guidelines, and we want to narrow down today on WHO SMART guidelines. Basically, this is a guideline. The SMART stands for specific, measurable, achievable, relevant, time-based objectives, which are generally meant to help in goal setting and planning when you are trying to develop systems for healthcare and even in other sectors. So as you saw in the HIS ecosystem where EMR exists, there is a lot of complexity that comes because of the many systems involved, stakeholders and such. At the global level where WHO is and guidelines are, the guidelines are very clear and specific. But as you go down the road during implementation to the Ministry of Health in the countries we are working, the technology partners we are working and sitting, the health workforce who are using our systems, and the end user, as you saw in the evolution where we expect users to have managed their own data, complexities arise and clarity is lost, and we try to depict this through this diagram. You can see the bars of the network reducing because more people are getting involved, more systems are getting into the ecosystem, and the needs of the users are broadening, and therefore making the process of creating personal record eventually for the health for the end user who's our patient and client more difficult. However, we note that these SMART guidelines using digital tools can make it easier, more standardized and localized for countries to adopt the guidelines. And as implementation proceeds down line, the traditional guideline often loses their clarity. So what we're trying to say here is that EMRs can actually help countries adopt these guidelines and avoid the complexities that we're going to highlight shortly that arise as this EMR starts to exist within the HIS ecosystem. So as you can see in this other slide, how are we operationalizing EMR in this broad ecosystem? How is EMR coexisting with these other systems that exist in the HIS? So we are trying to support the countries in this journey by doing a few things that we have seen results for. For instance, ensuring the supported system adopt these standards and digital development principles that meet local data and functional needs. By this, we mean we try to make sure that our solutions are localized, they are aligned to the national guidelines for those countries, that we build the capacity necessary to do this. Secondly, we support countries to enhance their information system for improved data quality, person-centered care, clinical decision support, program monitoring and reporting. This narrows down to being specific in our implementation, ensuring that we are addressing the needs of the client, and ensuring that we do not only have quality, but we are supporting the care providers in decision support, and we are meeting our client needs for monitoring and reporting. Next is supporting local context in requirements. As you saw in the SMART guidelines, one of them is a requirement being very specific, and here we try to localize them so that our requirements are aligned to our resources and are backed by global best standards. So we are not implementing these solutions without limitations, for instance, resources. So how do we make sure that our solutions are aligned? So we support this by making sure our work plans, our budgets are aligned to this need. Next is we support enhanced information system, governance structures, communities of practice, and in-country implementers. So if you think about the length in which EMRs need to exist, we have to build the necessary governance structures. We have to develop communities of practice and more importantly, have implementers in the country for continuity beyond the project, for purposes of ownership and building local capacity. And finally, as you saw, the EMRs exist in varied workflows. So we try to tailor our EMRs to be relevant to the workflows. And just to give you a highlight of the kind of scenarios we have of different kind of facilities, the same EMR is being used in a clinic with one caregiver, and the same EMR could be used in a referral hospital with hundreds, if not thousands, of caregivers and patients getting services in that facility. Secondly, you could have a different kind of implementation where you have one facility where they capture data through retrospective data entry once they have seen patients. You have scenarios where a facility is at a point of care, so they use the system as they do see the patient. And then we have a hybrid, which is a blend of these two. So we have to make sure that our EMR are relevant to these varied workflows in different contexts. However, this does not exist without any challenges, and we have observed some of these challenges during our operationalization. So one of the main challenges is the sheer number of stakeholders involved in HIS ecosystem, with, of course, expected varied expectations, and therefore it becomes quite a challenge to address all their needs at the same time. Another important challenge we have faced is interoperability and siloed systems. So for instance, when we want to exchange data, you find systems that are siloed, systems that are inoperable, systems that are appropriately, and systems that there exists no support going forward, which poses a great challenge for us when we are doing interoperability. Another challenge is resource constraints. As you can imagine, the needs are endless, yet resources are limited. And therefore, we have to contend with balancing what do we implement, what do we schedule later, and what do we postpone. Another challenge is that we, of course, face is resistant to change. As you can imagine, very many people are involved here, and you need to be prepared to do change management and build a case of why EMRs are needed, why you need to evolve and manage the patient better and bring on board people who are not into automation or digital as you build your systems. Another challenge is data security and privacy. And this issue comes across in two ways. One is that medical data has the highest value in the cyber space, and it's, of course, highly targeted. So one, we have to make our system safe. We have to make sure our data is meeting international and local standards. And we have to build not only the security in the system, but within our users to be aware of this need and to address it. And we shall highlight how we have done that as we go through the country examples. Then there is the other challenge of compliance with evolving regulations. Most of the countries we are working in have recently passed data privacy regulations that we need to comply with, including hosting our systems within the country and ensuring that our system meets those rules and regulations. And finally, another challenge we have noted is the smart guidelines are very new. So we have to first build the capacity locally with our partners and everybody we are working on, and build the case for them even as we try to build them within our system. So at this juncture, I would want to pass back to Pascal for the next slide.
Yeah, thank you very much, Patrick. Yes, we are referring to the WHO's SMART guidelines. not the specific, measurable, achievable, and time-bound. Yeah, we are referring to the WHO SMART guidelines in this context. And thank you, Patrick, for highlighting the challenges, but also the opportunities that we face. So we are going to get into 3 case studies around the implementation of EMRs across 3 different countries with different deployment models, different opportunities, different progress made in those countries, different lessons learned. So I hope that as we go through these different experiences, we'll get to pick a lesson or 2. We will start with Kenya, then we'll go into Eswatini, and then wrap up with Nigeria. So I will invite Evans Munene to take us through the Kenya case study. Evans.
Thanks, Pascal, for that. For Kenya, we're going to look at a system called Kenya EMR. Kenya EMR is a distribution of the global open MRS system that was adopted by the Ministry of Kenya as a standard EMR of choice in 2019 to mainly address HIV challenges in the country. This system is the model whereby we have multiple systems running at facility level, and these systems are implemented and managed at the facility level. We have a few instances in Kenya that are running cloud installations that are being led by implementers. This system is used as a point of care system, allows for use as a point of care system, allows for retrospective data entry, but additionally allows for hybrid mode of use where facilities that use it as point of care, whenever they have some challenges like power challenges, they are able to also turn back to retrospective data entry and switch in between the 2 modes easily. The system covers widely the HIV, the TB, the maternal and neonatal child health areas, COVID-19 vaccinations and tracking, OVC programs, KP programs, and non-communicable diseases as the core areas of its coverage. As shown in the diagram, we can see that the system is divided into 2 basically layers that are linked through various forms of interoperability or health information exchange to allow ease of its implementation. I'll start with the upper level at the national level. We have a robust interoperability layer that is FHIR and HL7 ADX enabled that allows for integration with reporting systems. On my left, we have the KHIS, which is the DHIS2 variant, and the National Data Warehouse, which are 2 very distinct reporting platforms. The KHIS deals with aggregate level data, while the National Data Warehouse deals with individual level data. Additionally, we support linkage with shared utilities, the health master facility list that deals with or stores all the health facilities in Kenya, the client registry, which is a unique patient identification system that helps in giving a number that is very key in ensuring that a patient can be uniquely identified across different program areas and across different facilities. The National Health Data Dictionary, which is an important tool for the country in ensuring that there are standards in how data is managed and integrated within the different systems. And then a service system, which is the early infant diagnosis and viral load laboratory service that is key in ensuring that there is timely resolution of lab results between the facility and the lab people in terms of testing. At the bottom level, we have various types of systems. We have a system that supports community initiative that is called Fiesta and HIS. These are mobile applications that are designed to support community health systems at the frontline in delivering care to the hardest to reach areas. These 2 systems are distributions of the global community health toolkit that leverage on the principle of reuse for open source solutions. At the middle, we have a service system called WebADT. This is a pharmacy system that is keen in ensuring that the dispense and information community management within a site are well managed. And these are linked with Kenya EMR to ensure that there's a smooth workflow managed within the 2 services. Towards bottom right, we have two other systems that are mobile applications. One is called Nishauri, which is a client support application that is key in empowering clients with the knowledge of their well-being and for clinical tracking. To the extreme right, we have P-Survey, which is a client engagement solution that supports root cause analysis in understanding clients or patients and the program for what data can be leveraged to promote program improvements or interventions for which the normal operations of data systems cannot aid in responding to the program. So this solution, Kenya EMR, being at the center of this, has a very robust community of practice that is supported both at the global and local levels. I think we'll look later. We'll look deeper into this. Currently, the solution is in 2,003 facilities. This represents 90% of Kenya's patients living with HIV/AIDS. That's over 90% of the patients who get HIV services are handled within facilities that implement or have an EMR with them. Kenya EMR covers 99% of all EMRs in the country, meaning it's the most commonly used EMR in the country. Next slide. Thank you. So we'll delve deeper to looking at achievements and challenges for this system. And I'll start with the first one towards the achievement section. Kenya EMR has adopted global standards in its management of data dictionary. It uses a CL global standard for this, which is also linked to the National Health Dictionary that we discussed earlier. For information exchange, it has adopted HL7 and FHIR standards to ensure that it communicates with the various systems within the overall digital health ecosystem. This means that it's built for integration and interoperability both at site and above site level. Kenya EMR additionally has been integrated with a machine learning model within the system that aids in providing person-centered care for interruption in treatment, for ensuring that HIV cases are found with ease, and also for promoting preventive measures in HIV, like the prevention of mother-to-child transmission, and prioritizing patients who should be getting prevention services like PrEP. Currently, as had earlier been shared by both Pascal and Patrick, we are in the initial stages of integrating the WHO SMART guidelines. We know these are layered in levels. Level 1, which deals with getting the narratives or implementing the narratives as guidelines for implementation. We've done level 2, where we've compared our national guidelines with the WHO digital adaptation kit guidelines to ensure that we are speaking the same language and we're able to have a similar definition of terms. Right now, we are in the phase that we're trying to incorporate the standard clinical quality language within the system that adopts the SMART guidelines as envisioned by WHO. So we are hoping we will be able to fully adopt these guidelines and implement them within the country. And also, Data.FI can also leverage on the work that they are doing in Kenya to quickly run this to other countries. To ensure that we are able to get data and use this, get this data being used in other countries within the country and other needs, we support both routine and non-routine data needs. How are we looking at this? For routine needs, we have inbuilt reports within the EMR that help to provide standard reports that are required by MOH and other users who need them routinely. For non-routine needs, we have integrated 2 tools. One is called Metabase and the other one Superset, which allow for users to be able to extract data that is not structured and to be able to gain insights at any moment within the system. But also additionally, we are able to pull insights from the national level through the National Data Warehouse, so that people are able to get things like data quality feedback, insights from other models that are running at the national level, and also program insights that need to be scaled down to the facility level. For collaborative partnerships at the global and local levels, we work very closely with the global open MRS community in ensuring that we are developing systems that are unique and key for the entire world. That includes things like the micro-fronted technologies that the community is currently prioritizing. At the local level, we have a robust community that drives the growth and expansion of the system that is extendable through an add-on module moving on from the achievements, we'll look at the challenges and what these mean during our learning lesson. So the first challenge I'll talk about is the maintenance costs. We know costs evolve based on user needs and can be substantial when they are not planned for. Normally, because of how we implement our model at the facility level, we know facilities end up having servers installed at the facility or PCs and all those things. These systems have a lifespan of around 4 to 6 years, depending on use and storage. So having implemented the project for the last 10 years, that means most implementers have had to change maybe their systems either once or twice throughout the whole facility. This has brought in a bit of a high cost on infrastructure, especially in ensuring that we are able to have the most recent systems that are able to scale within the facility. Number two, we have things like LAN or local area network that has to be maintained and extended to other service areas. Maintaining this over time requires routine and consistent changing to ensure that this is met. How are we tackling this? One of the ways that we're tackling proposing people to migrate to cloud, but this also brings in another challenge, which is aligning the OpenMRS architecture to support multi-tenant implementation. So we are working closely with the OpenMRS community to see how we can ensure that the OpenMRS architecture is robust and ready to be able to support such environments. Additionally, we have continuous enhancements that are required to meet the changing technology dynamic. We know technology is an ever-changing product. We know that the space keeps evolving every 2 or 3 years. Things have to change. Things have to be aligned to new data needs. Things have to align to changing user management approaches and all that. For this, again, we are also leveraging on our community to be able to have collaborative engagements to ensure that we are aligned to the global digital health trends and principles. The last bit is meeting competing diverse user requirements. How are we doing about this? We are thinking around working on with our users so close, such that we design our systems with the user in mind, and we also aim to availing optimized experience in their usage of the system. Additionally, continuous training, ensuring that we are training at all times, is important in this agenda. Thanks, and back to you, Pascal.
Thank you very much, Evans. And your overview of the Kenya system has elicited quite a number of questions around data security versus cloud hosting. The question on cloud hosting is a question of data sovereignty, and we will hopefully we'll have time to address that. I just want to make a note here that Kenya EMR is open source, and it's implemented in country. The code base is available on GitHub. But it's a customization or an implementation of the global good called OpenMRS. So I will not go into the other questions that have been raised. I believe some of them have been responded to. Kenya EMR is, I just want to point out that Kenya EMR currently is majority deployed in facilities. So each facility has a server. You have an instance of Kenya EMR deployed in that server. And why that is so is because of legacy issues. When we started off this journey, as Evans mentioned, that's over 10 years ago. Internet penetration was not as high, which I think is another question that has been raised. But right now, internet penetration has gone quite high because of mobile technologies. And because of that, we are seeing quite a number of facilities wanting to move to cloud-hosted in-country cloud-hosted instances. And that points to the point that Evans raised on the EMR architecture to support for multi-tenancy. So we'll move on to Eswatini. And the Eswatini deployment is very different from Kenya's deployment in that it's a centralized deployment of the EMR. What we have in Kenya is you have a decentralized, not distributed, a decentralized architecture where data is then sent centrally. But then in Eswatini, we have a different deployment architecture, which is centralized. So I'll hand over to Simba to take us through the Eswatini deployment of CMIS. Over to you, Simba.
Thank you, Pascal. Good morning, good afternoon, everyone. So yes, like Pascal has rightly put it, in Eswatini, our implementation is a bit different. We do have a centralized architecture whereby every clinician at facility level are actually interacting with the same instance of the CMIS itself. So our CMIS, like we call it, Eswatini CMIS standing for Client Management Information System. So this is a custom-built solution that has been built via Microsoft Technologies, and we are hosting this through the government network. And within the government network as well, with some facilities running the government network, but obviously the bulk of the facilities we had to leverage on the local cell phone service provider, which is MTN, to actually provide connectivity for the system itself. So basically, they have enabled that for us, for the clinicians to be able to actually access the system from the facilities. So it is a real-time point of care system. Whereby when a clinician is actually interacting with the client, they will actually be documenting the client information within the system itself. We have a target of about 330 facilities within the country, and out of these, 236 are now running the software. So 72% of the facilities within the country are actually, running, have been deployed within the CMIS. And we've got mainly the CMIS is the main EMR within the country. And out of all the EMRs within the country, it is covering about 96% of those EMRs. So it is a system that has been custom developed over a period of about 10 years. It started off with an institution called Institute for Health Measurement, an NGO from 2013. Another NGO took over in 2019 called FEI Systems. Then we took over the project in 2022. And one of the key things that we have implemented within the project is the ability for clinicians at facility level to be able to use data at that facility level. So basically, we've improved data usage facility level, mainly by building a custom, or rather building a DHIS2 based platform on top of the EMR for reporting purposes. So in the past, we'd have situations where the different clinicians or different data requesters would request data to a national level. The national level extracts data sets in Excel and pass them on to the facility level for reporting and analysis and things like that. But now is Data.FI, right? What we've then done is using this DHIS2 based platform, we are able to extract data from the EMR every night, run ETL processes, and be able to actually have clinicians access their data at the facility level. So it is a system that covers different programs across the whole medical spectrum. We have quite a number of achievements that we've attained as a country. The biggest one being the full government ownership of the application itself. It is a system whereby, as an implementing partner, we actually sit down together with the developers in one room to be able to develop the system. We are also trying to address issues around unique identification by implementing biometric solutions, the use of a thumbprint when searching for individual records within the EMR. There are a lot of collaborative partnerships we've implemented with the different implementing partners clinical implementing partners at facility level, assisting us to mentor clinicians that are using the system for, of course, to enhance data quality issues. I've already talked about data use at facility level, and also we are also tracking usability of the system using a dashboard whereby we'll be able to see which facilities are logged in at a particular point in time and when they last created records, basically in an effort to achieve data completeness. One of the key things that we're also doing is improvement in terms of security and privacy of client records. And one of the functionalities that we're currently piloting is issues around consent management, whereby a client would need to consent first before a record is opened within the EMR. So in other words, a client might need to provide their fingerprint, or we send an OTP to them. And once they receive that OTP, they tell the OTP to the clinician. The clinician punches it in, and they'll be able to open the record. So it's a pilot project that we're doing in an effort to obviously curb issues around security. There are obviously override methods in cases where clients are not available, but this is one area that we're focusing on. Definitely a lot of challenges as well on the project. As you know, perceptions are never the same, but we've also tried to implement the project by electing what we call facility champions. Facility champions are those individuals that are actually sitting at facility levels, clinicians that are tech savvy. We mentor these, we move with them, and ultimately they will be our ambassadors at facility level in improving the system. The dynamic nature of health programs, I've mentioned that we work very closely with local capacity, local developers in the country in trying to ensure that whatever changes that come up, we'll be able to implement them as fast as we can. Staff turnover is an issue as well, whereby, you know, from facility, there's always staff rotation, clinicians moving from a CMS facility to a non-CMS facility, and vice versa. Then one of the things that as a country, working with the Ministry of Health, we've started discussions in trying to introduce the EMR as one of the modules at tertiary level, at nursing schools, that is. So in other words, when nurses come out of nursing schools, they will at least be able to operate the system going forward. So these are discussions that are taking place, and obviously we'll be able to leverage on those going forward. And one of the things, again, that we can also talk about is issues around interoperability. We've also getting various requests of interoperating our system with the different systems within the country, including your lab information systems, your supply chain systems, among others. So again, we have started building a master patient index, whereby we are trying to at least be able to have all the demographics for the clients within a central repository, and have all the different HIS systems tap into this central repository, sharing the same unique identifier, or, you know, be able to, so that we'll be able to identify the same patient across the different information systems. And ultimately, from this MPI, Master Patient Index, we're envisioning a situation where we are going to be building onto it, and it becomes the shared health record for the country. So not only will be sharing demographic information, but we'll also be moving on to share clinical information. So with that, I think this is it for Eswatini. Over.
Thank you very much, Simba. You showed a different kind of deployment. Again, this was a proprietary developed system and handed over. Different partners were supporting the ministry, fully owned by the ministry, with a centralized setup, with different kind of setup in terms of the architecture, but certain underlying common challenges around security, privacy, consent management, and ensuring that point of care structure endures even when there's no power on. We looked at the Kenya EMR setup, which allows for retrospective data entry, POC, and a hybrid of the two. So now we'll finish our case study with Nigeria. And in Nigeria, we'll talk about LAMIS Plus. In Nigeria, there are quite a number of EMR systems, but the two most widely used in the HIV program is NMRS and LAMIS Plus. So we'll be talking about LAMIS Plus in our presentation. So on that, I'll hand over to Chris.
Thank you, Pascal. I'll try to be brief. We are almost running out of time. But so Nigeria, LAMIS Plus started off as LAMIS back in 2014, 2013. It was developed by FHR 360. In 2020, Data.FI came in. We constituted a community of practice led by the Federal Ministry of Health, with membership from across implementing partners in Nigeria. We also rebuilt LAMIS Plus from the ground up. It's fully open source. We have a modular architecture that powers community development, allowing small teams of developers to develop modules on top of the core LAMIS Plus application. It's designed to support both point of care and retrospective data entry. Our services offered range from outpatient reproductive health, HIV prevention, testing, and case management, as well as COVID-19 surveillance. And at just above 700,000 patients currently on ART, Lamis Plus accounts for 35% or so of PLHIV in Nigeria. We've built also seamless integration with national data repositories, lab information systems, and partner reporting systems, including dating. We've also implemented situation rooms at federal and state level in Nigeria, at both the Ministry of Health and the Ministry of Women Affairs and Social Development. Next slide, please. All right, so some achievements. I think for us in Nigeria, there are quite a number of achievements, but the community of practice and putting that together and seeing that in action is one of the big achievements. Other than fostering ownership, it also provides a mechanism, a proper mechanism for co-creation. And this spans, the entire life cycle from ideation to validation to design and development, quality control, deployment, training, and maintenance. Because of this, we've seen, a high level of acceptance and use. In the facilities that we have implemented Lamis Plus, around 617 facilities in the country. We see a very high level of use. All the patients are captured in the system. We are seeing this powering our data use strategy as well with the epidemic control rooms, the situation rooms that I just talked about. We have some data exchange happening between Lamis Plus and the OVC MIS for orphans and vulnerable children, being able to track beneficiaries across the care continuum. And, reporting is also very well supported, both Ministry of Health reporting and PEPFAR reporting out of Lamis Plus. Challenges, again, I'm not going to talk too much about. We have similar challenges to Kenya EMR. As we scale up, the infrastructure cost goes up. So we have tried to have that conversation about how do we adopt a centralized system, have a conversation about private cloud, how do we start to have a hybrid approach to see where can we actually deploy Lamis Plus in a centralized environment where the infrastructure supports it, and the policies allow for it, and maybe have a lighter version of in-facility implementations where the infrastructure still needs to catch up a bit. And here I'm talking about like the connectivity needs to catch up. There's some technical debt we have to address here. Lamis Plus being rebuilt from scratch. We obviously needed to redesign. We had to account for retraining people. We need to account for making sure functionality is carried over from the older system and such issues. But overall, everything is going according to plan, and we are looking forward to picking up experiences from other countries. Happy to see what's happening in Eswatini and learn from that, and from Kenya as well, so we can develop, we can improve together. Over.
Great. Thank you very much. I see quite a number of questions on chat, a lot of interest, and I see my colleagues my co-panelists are responding to a few of them. So we have just 5 minutes. I will not go into this in detail, but just our guiding principles out of the three cases shared. One is the importance of community leadership, ensuring that we are working with in-country partners. We have setting up a community of practice, ensure that we're designing with the users, and this drives ownership of the different technologies. There was a question I saw on chat asking, was these systems designed to be facility-wide systems or program-specific or disease-specific? The reality is that most of the investment came from PEPFAR, which meant that the initial investment focused on the HIV program, But now we are seeing a lot of interest to take a primary healthcare approach to support expansion of this. And this helps to drive ownership and expands the community in that sense. So the good things that we are seeing, most of these systems are expandable and modular and allow for additional use cases to be embedded. Designed for privacy and security, I think this is a big one. Many of the countries we're working in, there is adoption of data protection laws. So we are looking to ensure that with every design enhancement, we are designing with security in mind, not to inspect security, but to design for security. Build for sustainability, again, the 3 systems that we've talked about have been handed over across different partners, same government, but different partners supporting the government. We need to always have that in mind. How do you then ensure there's full government ownership, irrespective of whether or not it's donor funded or partner supported? And then finally, we always need to make sure that we link up the health information systems to the health outcomes. The health in HIS ensures that we are being data driven, that, you know, at the end of the day, the investments need to count for something, and that something is the improved health outcomes. So I think the highlight from Simba was that, you know, since last year to date, what we have enhanced really on CMIS is the data use aspect of it. If you remember the initial slides around the evolution journey is to a point of convergence to the client or the patient, right? And so we are addressing that client or that patient, and then the data needs will be addressed as exhaust data is gotten out of that. But essentially is to ensure that the patient and the client needs are met. Some key takeaways, there are common challenges, but different approaches in the 3 different countries, as you've seen. But there's also an importance of ensuring that there's a shared vision amongst stakeholders, ministries, the donor agencies or funding agencies, the in-country implementing partner, all need to have a shared vision, both around where the systems are currently and where they need to be. And that stewardship process, sitting with the ministry, is very important, and hence the need for strong governance structures that are ministry driven. The other is to ensure that you design for data use at all levels, at a national level, all the way to the client or the patient level. We need to design with that in mind. How is the patient going to interact with that data? How is the patient going to authorize or unauthorize access to the specific data elements? How are we ensuring that we are doing encryption and all that? Innovate with the user. In the evolution, we've seen at different points of the evolution stage, the definition of the end user has evolved with time. So initially it used to be the program team and the national team or the donor agencies together with the national ministries, and that has evolved over time, right? And so we need to have that in mind as we're designing the systems and enhancing them. There's need to understand the ecosystem and the different players. As we said, that's why it's important to have a standards-based approach as you take a local context approach to develop the systems, ensure there is community and country ownership, and lead with value proposition. Do not lead with technology. It's not the other way around. So unfortunately, we'll not be able to get into all the questions that you put on chat. Lawrence, I don't know if we have an opportunity to send out our responses to the questions that have been sent through on chat. I don't know if that's something that we can do, but we'd be happy to. But really, thank you so much for creating time to listen through this discussion. Thank you.
Absolutely. Thank you, Pascal. And thank you, everyone, for joining us. We apologize for running a little late, but there's clearly a lot to cover here, and we could have had a 3-hour webinar if needed. I think in the interest of time, we can kind of call it here and understand people might need to drop off. But I think our speakers will kind of still be available for a couple more minutes in case you have some burning question you would like to get answered. Yes, this webinar is recorded, so even if you've had to drop off, we will send the recording out so you'll be able to watch the whole conversation. So Pascal, Chris, all of our panelists, I don't know if you're available to stay for a couple more minutes in case anyone has. I think if we took a little bit longer, we might as well give our attendees a little bit more time. But thank you, everyone. So, deeply appreciate your attendance.
Thank you.
So yeah, if anyone wants to stay for a couple more minutes and ask a question, you are most welcome to do so. Yes,
Hi,
Kuibali.
hello.
Hi.
Yeah,
Yes.
thank you so much for this presentation. So, do you have any advice for how to get like country ownership? Any advice?
Yes.
Thank you.
Thank you very much, Veronique. Yes, I think we've hinted at that. I think country ownership is important from the sense of allowing the countries to take a lead, one, in defining what they require at their level, but also in being part of the creation process. What we've found across all the countries that we've worked in, country ownership enshrined in governance structures is a more sustainable way. So the governance structures, what I mean here is there a technical working group that defines, that brings different players together, that defines what the requirements are, brings the different stakeholder needs to the table, and vets what is being done in the health information system space. And once the systems are being developed, is there country leadership to then bring those systems to life and maintain them, right? And I think if you ensure that there's country engagement, country leadership engagement from the different ministries, right from the beginning, ensure that the right governance structures are in place, that's a sure way of ensuring that, you know, country ownership persists through the evolution of the system. I hope that answers your question. And I've seen another hand go up. Is there another hand?
Yeah, Meluli.
Thank you.
Yeah, go ahead.
Absolutely. Yes, thank you for these insightful presentations on the electronic medical record. Just to find out from Evans, in the case of Kenya, you mentioned that you use this unique identifier for each patient. Could you shed more light on how is this unique identifier like? Are you using an ID, or this is a number that is allocated to a patient upon admission or upon visiting the hospital? What is the nature of this unique identifier? And again, should I visit another healthcare facility, I maintain the same unique identifier? Is it tied to my identity, my ID number, for instance? What makes it unique and be able to identify a patient? Thank you.
Thanks for that. I don't know, Pascal, do I take that or you want to take that?
Well, you can respond to that. Thank you.
Thanks for that question. In country, we have the client registry, which is managed by the Ministry of Health. Normally what happens is that whenever a patient or a client is registered at a health facility, his personal details are shared to the client registry for getting that national unique number, which is also ran against the patient, the person registry system within the country, what we call the IPRS, that is key for providing all people with a national ID. So that is run against that, and then someone is able to get that ID that they can carry along within that facility and also across facility. So that number is shared for any service that you're getting within any health institution. So it's unique. It cannot you cannot get two because it's linked to your also ID number and other national numbers.
Yes, thank you, Evans. Just to clarify, the unique identifier is attached to one national ID number, and in Kenya, the uptake of ID numbers is quite high, so that allows for that. Secondly, it allows for passport numbers for aliens or foreigners. And for those who are under 18, it also allows for birth certificate number, birth registration number. So yeah, so it provides for different ways of registration linked up to the national government registration systems to then ensure that the validation is done in a way that is centralized and in a way that is verifiable. Does that respond to your question?
Yes, please. Thank you so much.
Thank you.
Sure.
Thank you for making time. Great. Are there any other questions? Any burning questions that have not been responded to? And thank you for taking the extra time to stay with us and interrogate this further. Yes, there's Bosco.
Bosco, I believe you were first.
Good evening. Good evening, participants. This is Bosco from Uganda. I'm so happy to be part of this, and it was such an insightful discussion. I've really enjoyed it. My question goes to Simba from Eswatini. As he was presenting, he hinted that in their country, they are implementing a biometric solution to capture the profile of the patients, but it is considerably a significant challenge in Uganda, as however much we have tried to use that innovation, we have failed to achieve it, given the fact that some of the people don't have, actually, some of the people, there is frequent misplacement of the IDs and all that. So how are you addressing that issue? And how did you actually achieve the biometric solution to be actually working very well? Thank you.
Thank you, Bosco. Simba, you can take that up.
Thank you very much, Bosco. Yeah, so definitely it's one of the solutions that we've come up with. Of course, we are not 100% there as yet. We do have challenges, like you rightly put it as well. It's not like it's a perfect situation with us as well. It's also one of the areas that we are battling with. But for us, I think our biggest challenge has mainly been on the procurement side, because you find out that what happens with our biometrics, within our facilities, we have several entry points. We don't have like one registration point where everybody comes through like that registration point and goes to the other service points. But because we have these several multiple service points, you would find out that probably the biometric is sitting in the registration point and not necessarily in the ANC department or in the TB department where they would want to get into the facility. So this is one area that we are really trying to focus on, but we haven't really had challenges in terms of clients themselves refusing on the uptake, refusing to use the biometric in that regard. So that has been the main challenge for us. It is mainly issues around ensuring that every service point has a biometric scanner sitting on it. And it's still one of the hurdles that we're battling with, but hopefully we'll get there. Over.
Okay, thank you, Simba. Yeah, so Lawrence, thank you so much. I believe we are 10 minutes over time. Unless there are any really burning comments or questions.
I think we'll call it now. I'll stop the recording. Thank you everyone who's still with us. If you have questions that weren't answered, we'll be sure to email you with an answer, and you'll get the recording of the whole presentation in tomorrow or the day after. So thank you once again, everyone. We really appreciate you sticking with us and hope you have a great rest of your day.
Thank you.